There we go, we're recording now. So this week is a continuation of last week, so we're going to continue with the respiratory theme. We've got Dr. Joe Shak presenting a presentation on VQ mismatch, dead space and shunts. So it's going to be start first. That should be about 15 to 20 minutes, and then we have a little bit of time afterwards for questions. We can use the conversation, the chat section, to ask questions like we did last time. And for anyone who's new, basically, yeah, use the chat section to ask questions.
Not tricky.
Pardon?
Not a tricky question.
yeah, we don't have any, unfortunately, we don't have any consultants here during this teaching. Usually we're going to try and get some, but unfortunately this week we couldn't get anyone. Oh, just some more people. So if you've got any questions, you can ask Jo. She's the most senior. After Jo's presentation, I'm going to be doing a presentation on respiratory pathology and anaesthetic implications of those, trying to keep it a little bit more clinical. It is another section that is in the exam as well. So all of these are exam topics, but they're also useful clinically as well. And then we've got Steph, who's going to do a quiz for us as well at the end. And that's going to be using the app Kahoot last time, like the same as last time. So that's kind of the plan of today. It shouldn't last more than an hour to an hour and a half. If you have got clinical commitments at the moment, then obviously stay as long as you can. And if you can't, then that's absolutely fine. Okay. Any questions or comments at the beginning, just pop them in the chat. If not, we will get started. So I'll hand it over to you, Jo, if you want to do your presentation.
Right, so I've already been introduced, but I'll introduce myself anyway. My name is Jo, I'm one of the FE3s. I can't answer any tricky questions because I only did primary myself a year ago and have learned very little since. But my topic of presentation is VQ mismatch, dead space and shunt, which if any of you have done the primary already will know how delightful it is. Oh, how do I move this?
So just at the bottom, you have to click the clicker at the bottom to change the slide.
This is a good start, isn't it? I don't even know how to move. Oh, there we go. Yay. Oh, come on. Hey, there we go. So here's the plan of my presentation. I'm going to spend a couple of minutes to try and explain why VQ mismatch matters, why shunt matters, dead space matters, because what I find about respiratory physiology is that it's just this long list of concepts in the West physiology or in your anaesthetic textbook, and I try to put it in a little context to make it seem important. And then once I've tried to justify the topic, I'll talk about some definitions, VQ mismatch, dead space, shunt. These are the Bohr equation and the Shunt equation are the ones that are relevant, and then I'll try and pull it all together in the West zones theory, and all the way along I'll try and make it relevant why it matters to what we see in everyday practice.
Sorry to interrupt you, Jo. Just one thing, if everyone could mute their microphones just so that there's no background noise, then we can hear Jo a bit more clearly, if that's all right. Thank you.
If you can hear a buzzing noise, it might be my laptop. When I was trying my mic this morning, there was just this constant hum. So that might be me.
Okay, but you can't mute. Sorry, carry on.
No. If I could mute the buzz, then I would, but I can't. So, what causes hypoxia? That's probably well, if any of you have been working on COVID wards, that's what you'll have seen more than anything else. But what causes hypoxia, VQ mismatch and dead space do come into this. It is a tiny part of why. If any of you have read a primary Viva textbook, you'll realise that hypoxia is one of the primary Viva questions. And of the 4 types of hypoxia, hypoxic hypoxia is the one that we're dealing with in this presentation. So when are we not effectively getting oxygen from the air to the lungs and then to the blood? There are other types of hypoxia which I'm not going to dwell over. The list is here for future reference. But like I said, hypoxic hypoxia is the one that we're dealing with today. And then that leads on to the next question, which is when are the situations when we can't effectively get oxygen from the air to the lungs to the blood, i.e. why are the lungs not efficient at gas exchange? Luckily, I've not come across this as a question in a textbook or in a Viva book otherwise, but if I was asked, then here would be my answer. Something about lung compliance when the lungs aren't efficient at expanding. When you breathe in, your air gets mixed up with water and carbon dioxide, i.e. the oxygen cascade. Diffusion impairment, so the inefficiencies of getting blood from the alveoli to the blood itself, and that is covered under Fick's law. But all of that is the rest of your respiratory physiology textbook. What we're dealing with today is dead space, i.e. parts of the lung which get ventilated but don't come in contact with blood vessels, and shunt, which is areas of the lung which get blood supply, and these are the areas of the lung which cause or contribute to hypoxia, and this is what I'm going to focus on for the rest of the presentation. So next thing I'm going to go and do is to talk through VQ mismatch, dead space and shunt in turn. So the first thing I'm going to talk about is VQ mismatch. So what is VQ mismatch? Like I said, in order for efficient gas exchange, you need areas of the lung where gas comes into close contact with blood. So if you have the same amount of gas and the same amount of blood in all areas of lung, that is ideal VQ mismatching, V being ventilation and Q being pulmonary blood flow. So at rest, your body, the total alveolar ventilation, i.e. the alveoli that gets air, is about 5 litres. The total pulmonary blood flow is also about 5 litres. So overall, your lung, the VQ ratio is about 1. However, there are areas of areas throughout the lung where that isn't perfectly matched, and that's when we get VQ mismatch. So in areas of lung where we don't have enough ventilation, so you get blood, but you don't get gas passing next to it, that's areas that we call shunt, and I'll go through this again in a bit. But i.e. V is less than Q, so your VQ ratio is less than 1. And then you also have areas of the lung where you have inadequate perfusion, i.e. you're getting enough air into the lung, but you're not getting enough blood to those areas of the lung. And these areas are called dead space, i.e. your ventilation is more than your blood perfusion, and therefore your VQ ratio is more than 1. Neither of these are good. Your ideal situation is when VQ equal to 1 is when you have ideal VQ matching. Anything else is mismatch and is inefficient gas exchange. So talking about dead space in a little more detail, as I've mentioned, dead space is any areas of the lung where you're ventilating but not perfusing. So you're getting gas in but no blood. There are different types of dead space in the lung. So the first type of dead space that we need, is that you? Hi, Kaya. You can't talk about, never mind. Anyway, anatomical dead space is areas of the lungs that are just not designed for gas to come into contact with blood. So this starts at your upper airway, it includes your trachea, includes all your conducting airways all the way down to the level of the bronchioles. At the level of the bronchioles, you start having alveolar outpockets, and that's where you start having actual gas exchange. Random MCQ fact, generation 16 is the last generation. So generations of your airways, your trachea is generation 1, your main bronchi is generation 2. So all the way down to generation 16 is anatomical dead space. Anything from junction 17 to I think 23 are your gas exchange airways. The total anatomical dead space, MCQ fact, is 2 milliliters per kilogram. So in your 75 kilo man, this would be 150 mil. Another MCQ fact, this is measured by the Fowler's method. It is a graph in your textbook which you need to read and learn, and then in my case present it because I find it confusing. This is what it looks like. Essentially what it is, you breathe in one breath of 100% oxygen, and then you breathe out, and all the gas that you breathe out is captured by a nitrogen concentration analyzer. And the beginning bit of your breath contains no nitrogen because it's just the oxygen that you've just breathed in. So that's your anatomical dead space. There's no mixing. You literally just breathe this oxygen in, straight back out again because nothing's happened to the oxygen. And that beginning bit is your dead space. And then there's some stupid explanation about bit of nitrogen. But anyway, just read it, and for MCQ, oh God, sorry. Ah, what's happening? I've lost it. Screen share. Sorry. Oh. Can you see my screen yet? Don't tell me you can see my screen again. Could someone do me a thumbs up if you can see my screen?
Oh, we can see your screen now. Yeah, it's back to how it was.
Thank you. Yes, just read about this experiment. If you can't remember it, then just know that Fowler's method measures anatomical dead space. That's the important bit. The rest of it is just detail. So after your anatomical dead space, you've got alveolar dead space. Alveolar dead space is the gas that gets to your alveoli, should be able to undergo gas exchange, but can't for whatever reason, because there's not enough blood perfusion, which is your dead space. In young, healthy lungs, this shouldn't account for much at all. And then finally, physiological dead space is the total of your anatomical dead space, i.e. your conducting airways, and alveolar dead space. So that's your alveoli that aren't very efficient. MCQ purposes, Viva purposes, this is measured using the Bohr's equation. So this is what Bohr's equation looks like. Bohr's equation, it compares essentially your arterial carbon dioxide with your alveolar carbon dioxide, because in an ideal world, all the carbon dioxide that is in your arteries ends up in your alveoli in an ideal situation. But the difference between the two is your inefficiency, and that is your dead space. This is what it looks like. There you go. Arterial carbon dioxide, end-tidal carbon dioxide, and just read it, and then most textbooks will tell you how to derive it. You won't need to derive it in the Viva, but it helps to know where it comes from. Again, if you remember nothing else, Bohr's equation, dead space at the end. Why does dead space matter in real life? Because I'm sure you've all seen this is particularly important in ITU patients, where you've got the end-tidal CO2 whizzing up and down on the screen, and it's 5, and you're thinking that everything is great. You do the ABG, and the PCO2 is 10. And you can try and drive the ventilation all you like, but if that patient has shot lungs and they've got lots and lots of dead space, you can inflate the lungs all you like. Because there's loads of dead space, you're never going to get that end-tidal CO2 down. You just have to fix the underlying reason for the dead space. So that's why dead space matters. Moving on to shunt, I'm guessing I'll take questions about dead space later, unless if anyone has anything desperate to say now. But moving on to shunt. So shunt, opposite to dead space, is areas of the lung where you have perfusion but no ventilation. So your blood vessels are going past your lungs, aiming to pick up oxygen, but there's no gas for it to pick up oxygen from. Again, there are different types of shunt. The first type is true shunt. So this is blood that is just destined never to go past the alveoli because of anatomical reasons. So one of the types of true shunt is bronchial veins. So these are blood vessels that go to the lungs, supply the lungs, but just never bypass alveoli. So they just supply the lungs and then go straight back to the heart. The second type are the Thebesian veins, I think that's how you pronounce it. Thebesian veins, so these are blood vessels that supply the myocardium, but they drain into the left side of the heart instead. So the blood goes to the heart, supplies the heart, goes straight back into the left side of the heart, and therefore don't go to the lungs ever. So these two causes will be a bit of shunt. This is the part of the blood that never ever comes into contact with oxygenated gas. And then the second type of shunt is physiological shunt. So these are just bits of your alveoli that are just less efficiently placed, and they go to the alveoli. There just happens to be no gas there, and that also causes a bit of shunt. And this exists in healthy lungs, and I'll talk about that later. Finally, pathological shunt. So these are situations where you have shunt beyond what is normal. Important example are cardiac defects. So your right to left shunt, where your heart goes straight from your right side of the heart to the left side of the heart, bypasses the lungs altogether. And various types of pulmonary disease, pneumonia, pulmonary embolism, anything that causes more mismatch in the lungs between perfusion and ventilation. There is an equation. It is the shunt equation. So as I mentioned a couple of minutes earlier, Bohr's equation for dead space compares alveolar and arterial carbon dioxide. The shunt equation compares arterial and alveolar oxygen. This is what it looks like in the green down here. This is the diagram that helps you derive it. You do need to know how to derive it. Again, they would never ask you to actually derive it in the Viva because it's time. But you need to be able to draw the diagram. By the time you've drawn the diagram, they'll be like, okay. But yes, just if nothing else, remember that the shunt equation is well, allows you to estimate shunt, and it compares alveoli with arterial oxygen. Why does shunt matter in real life? So shunt matters in real life because it explains why when you have a hypoxic patient, you can keep increasing your oxygen levels on your ventilator. It won't make a difference, your patient will remain hypoxic. Because if they have a high shunt fraction, i.e. 20% of the blood that goes to their lungs just never comes into contact with alveoli, so that would be this. So this is the shunt graph. You've got inspired oxygen along the bottom, arterial oxygen on the side. If you've got 20% shunt in your circulation, then you can see you can increase your oxygen all you like, up to 100% oxygen, you'll still not get much of a PO2. Maybe these are our COVID patients, our ARDS patients. If they've got 50% shunt, you can give them 100% oxygen, you'll still get a PO2 of 7. We've all seen that. So that's why shunt matters in real life. Pulling that all together, West zones is a theory which explains why lungs aren't 100% efficient. And essentially the underlying principle of West zones explains that ventilation and perfusion is distributed unevenly through the lung. Different patches of lungs receive different proportions of the cardiac output. They receive different proportions of the breath that you take in. As a general rule, both ventilation and perfusion increase as you go down the lung. So at the top, there's the most ventilation, there's the most, dial back. They both increase from top to bottom. At the top, you don't have a lot of ventilation, you don't have a lot of perfusion. But as you go down the lung, there's more gas, more blood. However, the rate of increase for perfusion is more than ventilation. And I'm laboring this because this helps you remember how to draw the graph, which will help you. So rate and degree of change for perfusion is more than ventilation. So the line is steeper. And then the interaction between the pressures in the arterioles, in the arteries and in the veins and in the airways determines the degree of VQ matching or mismatch in these different zones. And I'll explain these in a bit right now, actually. So here is a lung. You can all see my arrows on. So we've got 3 different zones, zone 1, zone 2, zone 3. And remember, as I said, both ventilation and perfusion increase as you go down the lung. The amount of perfusion increases more than the degree of ventilation. So if I go through zone by zone in turn, we've got zone 1 at the top. So at zone 1, there is ventilation and there is perfusion. And at zone 1, ventilation is more than perfusion. So P capital A here is airway pressure. So your airway pressure is higher than your arterial pressure, which is higher than your venous pressure. So in this situation, your alveoli are distended and they will compress, this is all theory by the way, your alveoli are distended and they will compress your blood vessels. And if it does this to the extent that you only get your alveoli inflating but no blood flow, what is that? You've got ventilation with no perfusion, which is dead space. So in this theory, at the top of your lungs, in zone 1, ventilation more than perfusion, the top of your lungs is dead space. Makes sense? Zone 2, so if you move a bit further down the lung, you've got more ventilation, but you've got more perfusion still. So at this point, your arterial pressure starts to increase and overcome your airway pressure. So in zone 2, we start to reach a happy medium where your arterial pressure is more than your airway pressure, so you can get both blood in, upgraded by the host. You've got arterial, so you've got blood coming in, alveolar pressure, so you've also got air coming in, but your airway pressure is higher than your venous pressure. So you might think, oh, does that mean that blood can, if you collapse your veins, then you're in trouble because then you get congested lungs. But because as you take a breath in and out, as your heart beats, these pressures change. So in this ideal situation, in this sweet spot, which is zone 2, you do get airflow and you get blood flow. And my book calls it the waterfall effect because of the change in the blood pressure, in the pressures as you take a deep breath in and out. The long and short of it is zone 2 is your sweet spot where you get blood and you get gas flow and you get gas exchange. And then zone 3, right at the bottom of your lungs, like I said, perfusion increases as it goes down to the lungs more than the ventilation. So by the time you get to the bottom of your lungs, you've got high arterial pressures, you've got high venous pressures, and your airway pressures are at the lowest. At the extreme, this means that your blood vessels will start compressing and collapsing your alveoli. So you've just got blood flow, but you've got no ventilation. And like I said, if you've got blood flow but no ventilation, this is shunt. So in zone 3, right at the bottom of your lungs, that is shunt. And again, that is inefficient gas exchange. In reality, in your sort of spontaneously breathing upright person, most of your lung should ideally be in zone 2, because otherwise we'd be hypoxic all the time. However, like I said, why is this important? Consider if you have high airway pressure, so if you start giving someone positive ventilation, especially if you start giving someone really high peaks, peaks of 10, peaks of 15, and then you have your peak pressures at 30 as well, what are you doing? You're actually artificially inflating your airway pressures, and you're risking turning your whole lung into a zone 1 type scenario. So yes, you're getting airway pressures, you're getting tidal volumes, but theoretically, if you compress all of your blood vessels, then you're just converting your entire lung into dead space, which is why just keep increasing your airway pressures isn't necessarily a good way of increasing gas exchange. On the other end of the spectrum, so when situations where your lungs all turn into zone 3, so in pulmonary hypertension, if you have high arterial pressures and high venous pressures all the time throughout your whole lung, you are risking compressing all of your even healthy alveoli, and you just end up with a whole lung of shunt. Or basal atelectasis, why do your airways at the bottom of your lung collapse, especially in anaesthetics, especially in obese people? Your airways are at risk of being compressed by your blood vessels in the first place. If you have any degree of pulmonary hypertension or anything that impairs your airways being open, you get basal atelectasis, you get increased shunt. The arrows at the bottom. Sorry. Oh, there we go. Oh yeah, here's the graph that I promised. So like this graph just summarizes everything that I've said. You've got the lung apex over here on the right, lung base over here, perfusion and ventilation at the top. And as I said, they both increase as you go towards the lung base, but perfusion increases more than ventilation. So the line for perfusion is key. At the top of the lungs, your VQ ratio, you've got more ventilation and perfusion. Your VQ ratio at the top of the lungs is about 3. As you move down the lungs, this is your sweet spot here where your ventilation meets your perfusion. You've got a VQ ratio of 1. As you keep going down the lungs, you've got way more perfusion than you have ventilation, and your VQ ratio is about 0.6. That graph just exists. Anyway. Like I said, West zones, it is just a theory, as I said. In real life, the variation isn't just from top to bottom, it's actually in 3 dimensions all the way around the lungs. If you've got diseased lungs, if you've got emphysematous lungs, you've got bully, you've got bits of consolidation, again, all of that goes out of the window. And if you're standing up, that's different from when you're lying down, it's different from when you're prone, it's different from when you've got your patient on either side, the right and left side. So that's why proning works when you have a patient with ARDS, and that's why when you've got someone with left-sided pneumonia, sometimes they do better on the left side, sometimes they do better on the right side. Every time you're moving the patient, you're changing the differences in ventilation and perfusion throughout the lungs, and you're all the time trying to improve the VQ matching of the lungs. So that's why this stuff sort of vaguely matters in real life. It's not just in the textbook. Just a side note on hypoxic vasoconstriction. So all this time I've been saying that the lungs are really inefficient. There are areas where there is lots of blood flow but not ventilation. One of the ways the lungs tries to overcome this is by a mechanism called hypoxic vasoconstriction. So this is where your blood vessels, they have this inherent ability to vasoconstrict in areas where they're not receiving oxygen. That just happens. And it is a mechanism of overcoming those areas where there's more perfusion than ventilation. And so it's just the lungs' inherent mechanism of EQ mismatch. It does go wrong. There's a whole big paragraph about it in the textbook, but I just thought I'd mention that here because it makes the situation a little bit better than what I've solved it on. So in summary, all the take-home messages, that's a lot of information. If you remember nothing else, remember that dead space is areas of gas without blood, and you measure it using Fowler's method of Bohr's equation. Shunt is the opposite way around. Shunt is areas of blood without gas, so perfusion without ventilation, and you measure or calculate that using the Shunt equation. VQ mismatch is anything that happens in between. So dead space and shunt are the extremes. There are bits in between, so VQ mismatch just draws some nice curves and lines in between. Weststones pulls it all together and sort of looks at the whole lungs and describes patterns of how this changes throughout the lungs. But like I said, prone patients, lateral acute patients, disease throws it all out. There are my references, my 2 books. Thank you. Any questions? I hope that made sense. It's really difficult talking to silence.
Thank you, Jo. Thank you so much for that presentation. If anyone does have any questions, then please put them in the chat, the comments box area, and we can leave a couple of minutes now if anyone has any questions to type them in.
Where do I see the questions? Where do we type? Oh, there's a chat button.
Yeah.
All very
a little chat on the side. Okay.
Stone silence.
That's fine. You explained it so clearly that no one has any questions. Good job. Thank you so much. Okay, so I'm going to do a presentation now, the one that I was supposed to do last week. It's basically building on what Jo's explained to us and kind of relating it a little bit more clinically. So it's still useful for the primary, but it's also useful clinically. So for people who've done the primary, it should also be useful. I'm trying to include everybody. So now I have to use the tech and try and work this out. So I screen share. Okay. All right, can you all see my screen now? Great, thank you. Okay, so I'm going to be talking about, so for those who don't know me, I'm Shivani, I'm one of the CT2s. So again, not very senior at all, so don't ask me too many questions. I've done the primary and this required a lot of kind of remembering because it's been a while since I've done it. So I'm going to talk about respiratory pathology and how an anaesthetic affects this. So the learning outcomes are to understand how respiratory physiology is affected by an anaesthetic, and then considering anaesthetic techniques or considerations for common respiratory pathologies. So I'm going to talk in detail about respiratory infections, obstructive diseases, restrictive diseases, and obstructive sleep apnea. So I've tried to split this up into a way of describing the clinical effects of general anaesthesia on lungs, of how you can speak about it in the viva. So it's very important in the viva to categorize all your answers. So I've tried to do that in this presentation for those of you who are preparing for vivas. So I split it up into lung mechanics, gas exchange, and airway devices. So if we go to lung mechanics, when a patient is under general anaesthesia, they have a reduced FRC, functional residual capacity, and this can be reduced by about 15 to 20%, generally due to the patient being in a supine position, having relaxation of their chest wall muscles, and surgical procedures and acute abdomen can cause this as well, and having pneumoperitoneum as well can cause reduced FRCA because of direct pressure. When a patient is in supine position. As you know, the closing capacity begins to encroach on the FRC, and that can cause hypoxemia. That's more pronounced the older the patient gets, and also, of course, the positioning. So it's worse in the Trendelenburg position, for example. Expiration becomes active under general anaesthesia, and you get reduced lung compliance as well. Low lung volumes present in general anaesthesia cause reduced airway radius. Now, if you think back to Dr. Marriott's talk last week about flow, if we think about the Hug and Purcell formula, which is, I have to quickly look at it, is flow equals change in pressure times pi r to the power of 4 over 8nL. Now, in this equation, the main point that I'm trying to pick out is the radius is to the power of 4. So every little bit of reduction in the radius of the airways causes a increased resistance to the flow by a power of 4, which is basically greatly increases the resistance to flow, pulmonary vascular resistance, and worker breathing for that patient if they are spontaneously breathing. Having a reduced mucociliary transport as well can lead to buildup of secretions. Of course, the patient on general anaesthesia can't cough and clear secretions. Depending on the length of surgery, this could lead up to a buildup of secretions causing infection. Moving on to gas exchange, you get increased VQ mismatch, and of course we've just heard all about that, so I'm not going to dwell on that. There's increased risk of atelectasis under general anaesthetic, and this can be split up into absorption atelectasis and compression atelectasis. So I'll briefly explain them. Absorption atelectasis is because in a normal ventilating lung, nitrogen remains within the alveoli because very little diffuses across into the capillary. It's not very soluble. So this splints open the small airways in the alveoli. Once you start adding nitrous oxide to the mix, nitrous oxide is extremely soluble, so that diffuses across the alveoli, and this could lead to small airway closure because it's not splinting open the airways anymore. Compression atelectasis is basically what it says on the tin, compression from reduced diaphragmatic tone and from abdominal contents as well, pressing against the diaphragm. So those are two types of atelectasis. Intermittent positive pressure ventilation. Now, this can cause the theoretical West Zone 1 that we were discussing before at the apex. So because of changes of intrathoracic pressure, basically you get a lot more dead space at the top of the apex, basically inside the lungs. You get impairment of the hypoxic pulmonary vasoconstriction, which is the protective mechanism of the lungs against shunt. So this occurs because of the volatile anaesthetics and can increase the VQ mismatch. And lastly, diffusion hypoxia. So this, I'm going to explain it again very quickly. This is because, again, nitrous oxide, when it's used, it's extremely soluble. It's more soluble than nitrogen. And because of this, it enters the alveolus faster than nitrogen can leave. And then this basically causes a dilution within the alveolus and small airways. So there's less of an oxygen concentration and less of an oxygen partial pressure. Therefore, the concentration gradient for oxygen to get across the capillaries to the capillaries is reduced, if that makes sense. And lastly, airway devices. So putting an airway device in any patient can cause a risk of laryngospasm, also a risk of bronchospasm, especially in those who have reactive airways, such as asthmatics or smokers. Inserting an airway device bypasses the normal humidification processes that occur in the nose and the pharynx. So using a HME filter in these, well, in all patients is extremely useful and kind of a must. You get loss of physiological PEEP because the airway device bypasses the pharynx. So adding 3 to 5 centimeters of water of PEEP onto the ventilation when a patient is in theatre is very useful. Airway devices cause increased work of breathing, again because of the smaller radius, and increase the dead space. So I'm going to go on to anaesthetic agents now. So volatiles, I'm going to start with volatiles. They increase the respiratory rate and decrease the tidal volume. They can act as bronchodilators, and they blunt the response to hypocapnia. IV induction agents, so mainly talking about propofol here because it's the main one we use. You get an initial stimulation of breathing, and that's followed by a depression and most of the time apnea. You get depression of airway reflexes, which allows us to insert LMAs and eye gels. And of course, ketamine is always different from all the others. It's actually a bronchodilator, allows spontaneous ventilation, and preserves the airway reflexes. Neuraxial blockade, so this can cause weakness in the intercostal muscles. Of course, it depends exactly on the level of the block. It's a particular problem in obstetrics where you have to have quite a high block of about T2 to T4. So it can cause weakness in the muscles, and inability to fully inspire, and a weak cough. Of course, if the spinal becomes even higher and compromises the phrenic nerves, so C3 to C5, that's a very high spinal, and that's when you get respiratory compromise, and it's an emergency situation. Muscle relaxants, okay, this is a bit of an obvious one, but inadequate reversal at the end of surgery can cause many respiratory problems later on. Atracurium can cause histamine release, and that can cause bronchospasm, especially in asthmatics. And you've also got to always think about Suk's apnea. Analgesics, so opioids kind of cause depression of the respiratory center and blunt the response to hypocapnia as well. Morphine can cause histamine release, and stronger opiates such as fentanyl and alfentanil can cause chest wall rigidity as well, theoretically. The other risk of in asthmatics is bronchospasm with NSAIDs, and apparently 10% of asthmatics do get this, but it's better to avoid them. So post-operatively, things to consider. Complications, pulmonary complications can occur, especially because of the reduced FRC, basal atelectasis, and the increased VQ mismatch can occur for a couple of days after the patient has been woken up. Bearing this in mind, it's very important to give supplemental oxygen to all patients post-operatively. Inadequate analgesia can be a problem, as patients can't breathe fully, they can't cough, and this can increase the risk of respiratory secretions building up, causing atelectasis and causing infection as well. So always make sure adequate analgesia is given to patients post-operatively. Try and think of other ways to reduce the amount of pain, so for example considering laparoscopic surgery or regional pain relief or regional anaesthetic techniques. Post-op shivering is a problem because it increases the metabolic demand for oxygen in a patient who's already at risk of becoming hypoxic. So we need to avoid this by maintaining normothermia and giving supplemental oxygen. And we've already talked about inadequate reversal as well. So preoperative risk stratification is very important in patients, all patients, especially ones with respiratory pathology. So let's talk about the pathology now. Upper respiratory tract infections can cause increased secretions and increased airway reactivity, and that increases the risk in bronchospasm. Lower respiratory tract infections such as pneumonia, it's difficult to clear the secretion. Sometimes patients even have a complete whiteout in one of the lung fields. So it's important to optimize these patients before surgery. So as you can see in this little diagram here, if you get a mucus plug at the bottom of a lung, or if you get a mucus plug, that basically switches off all of the ventilation to that lung, causing a shunt. And this blood, because hypoxic pulmonary vasoconstriction is inhibited or kind of reduced in a lung that's under general anaesthetic, this means that the shunt fraction is bigger and can cause more issues. So in elective cases with respiratory infections, it's important to postpone them for 6 to 8 weeks until the infection is cleared or treated. With regards to emergency cases, of course, these decisions are never left to us. It's always consultant decisions. But again, considering regional techniques, measuring the risk with the risk of sepsis if they're already a septic patient, giving epidural analgesia, good analgesia, and of course, using opiate-sparing techniques. Use of an LMA is good because it's less stimulating to the airways and reduces the risk of laryngospasm. However, a tube is much better control of ventilation, and it allows suctioning of extra secretions. The ventilation strategy for patients with respiratory infections would be a high PEEP and a high FiO2, taking them to HDU or ITU post-op, good physiotherapy post-operatively, and using humidified oxygen. So obstructive lung diseases, I'm not going to go over the pathophysiology of asthma or COPD because you already know that. I've just included it in this presentation for completeness. But again, it's very similar to respiratory infections that assessing the severity and optimizing the patient pre-op is important. Considering nebulizers, and if the patient takes inhalers, and giving them some puffs before taking them down can cause bronchodilation and help with the oxygenation of that patient. Always got to think about steroids. If the patient's on steroids, they need to be doubled, and there's been some new guidelines that came out earlier this year, so it's pretty useful to read over that. I've included a little diagram of the Kapner graph shown in obstructive lung disease. So you can see you get an upsloping plateau, and this is because the alveoli empty at different rates. So a ventilation strategy for these patients would be having a longer expiratory phase to prevent the gas trapping that can occur. This is good, however, it can increase the inspiratory pressures as the inspiratory time is shorter. Having invasive monitoring such as an arterial line can allow for APGs. Always, again, got to think about NSAIDs. I've already mentioned this, 10% of asthmatics can get bronchospasm with NSAIDs. Minimizing drugs that cause histamine release, and if you're using morphine, then always give it slowly, and think about whether you can use something else, and ITU H2 post-op if required. Now, this is just a slide that I included because it shows how much the benefits basically of stopping smoking can help a patient. So if a patient stops smoking just literally a few days before the operation, they can improve their carrying capacity by reducing their carboxyhemoglobin level significantly in just 12 to 18 hours. All of the other benefits kind of take a little bit longer. So if a patient is elective, then you can optimize them by trying to ask them to stop smoking. Good luck with that. But just a few days, even a few days before, or stopping smoking kind of a few hours before, can be beneficial. So definitely always advise patients to stop smoking. Briefly, I'm going to talk about restrictive lung diseases. Again, I'm not going to go through the pathophysiology because you all know that. Restrictive lung diseases can cause reduced FRC, reduced total lung capacity, but they have the same residual volume. Okay, so this means that their lung compliance is reduced as well. So they need high inflation pressures in order to ventilate these patients. That increases the risk of barotrauma and volume trauma as well. So if you get a sudden increase in airway pressure, then you need to think about whether or not there's a pneumothorax. You get increased risk of hypoxemia because of VQ mismatch, pulmonary hypertension and core pulmonale, and a lot of comorbid diseases can be associated with restricted lung diseases. So you've got to think about those as well, especially when you're seeing them preoperatively. So think about things like rheumatoid arthritis and assess their airway very carefully. The ventilation strategy for patients with restrictive lung disease is to have small tidal volumes, because obviously they've got a reduced total lung capacity and high respiratory rate in order to get ventilation, the oxygen in. And again, thinking about whether they're on steroids, immunosuppressants, or oxygen as well. Lastly, sorry, I know it's been a bit of a long talk. Lastly, I'm going to talk about obstructive sleep apnea. Now, the definition I found for this was partial to complete airway obstruction in sleep with no airflow for more than 10 seconds, more than 5 times per hour. The stop band questionnaire is something that I've included here. It's very useful for risk stratification and finding out whether the patients are at risk of having obstructive sleep apnea. A lot of patients are not diagnosed at the moment, so it's extremely underdiagnosed. And when you see patients and they fit this criteria, kind of having a thick neck, having a high BMI, being over age of 50, then it's useful to use the stop band criteria to assess their risk. Patients with OSA have chronic alveolar hypoxia, and because of hypoxic pulmonary vasoconstriction, this can lead to pulmonary hypertension and right heart failure as well, and also polycythemia because of the hypoxia. So with these patients, clinically, preoperatively, hopefully they would have had sleep studies if they've already been diagnosed. Having an echo and having blood tests is useful. Most of these patients are on CPAP, and if it's an elective surgery, they should be on CPAP for at least 3 months before the operation. And you need to give these patients good pre-oxygenation. So you need to prepare for a difficult intubation because these patients have a thick neck, they have high BMI, maybe use the Oxford pillow, and have the McGrath ready because they probably will be a difficult intubation, and they're very difficult to ventilate as well using the mask. Ventilation strategies would include using high PEEP and definitely opiate sparing techniques for pain relief, and they should be extubated fully when they're fully awake. So basically reduce the risk of obstruction when the airway device is out. Post-operatively, it's best to keep these patients monitored overnight, put them on their CPAP pretty much straight away, otherwise they could start to desaturate, and having serial ABGs is useful in this patient. Okay, so in summary, the take-home messages from this are, if assessing or seeing a patient, taking a patient to theatre who has a respiratory disease, ensure that you've had a detailed history examination and investigations carried out, as with most patients really. A good risk assessment, if it is possible to optimise them prior to elective surgery, then that's the best strategy. Limit pre-medications, especially sedative ones, because can cause airway obstruction. Consider regional techniques for pain relief whenever possible. Invasive monitoring such as arterial lines for taking serial ABGs is useful. Ensure good analgesia. Physiotherapy post-op is useful as well, and consider whether they need HDU or OTU. So hopefully I've covered all the learning outcomes, so you can understand the respiratory physiology and how it's affected by an anaesthetic. This is a question that could come up in a Viva, and I've used this book actually, it's really useful. The one I've used is Basic Physiology for Anaesthetists, and it's got like a section in it about anaesthesia in the lung, and I thought that was really useful clinically and for the Viva. And I've talked about respiratory pathologies as well, which is useful for the clinical scenario in the Viva. So if you've got any questions, let me know, and if not, thank you. These are my references and resources that I used. MasterPass is also really good, especially for OSCE Vivas, as it breaks everything down and categorises it. The Basic Physiology for Anaesthetists that I've just talked about is the one I used for the MCQ, but it also was useful in the Viva as well. And of course, BJ Education and e-learning for healthcare. Okay, let's stop sharing that. So yeah, if you've got any questions, you can ask Joe. If not, Steph has kindly prepared a quiz for us. So if you want to turn your videos and microphones on, then that's up to you, and that would be great. But if not, then that's absolutely fine. I'm going to hand over to Steph.
Hi guys. So yeah, this is the interactive bit, so please feel free to turn on your microphone so I don't feel like I'm talking to myself. So I have made a respiratory physiology quiz, which is largely for the primary. We've done it on Kahoot like we did last time. The problem with Kahoot is it only lets 10 people play it, so I don't know who wants to stay and do it. If not, I've done the same quiz on PowerPoint, so we can do it that way too. It depends how many people want to stay and do.
I am happy to opt out.
But let's see. Well, I'll put the quiz up and then we can see who wants to play. Let's work it out first. So up to 10 players.
So I think people who are still to do the primary, the MCQ, this quiz is only for you. Oh, there's the sound.
Yeah, sorry.
The
Okay.
good sound.
Sorry. Okay, let me share this with you, and then you guys will be able to put this game code in if you want to play along.
Have you guys all got the app Kahoot on your phones? If you haven't, download it now. It allows this to be interactive.
Just in the process of downloading it.
Okay.
So there'll be 10 questions. They're all taken from books I used for the primary myself. And they are, well, largely to do with what we've talked about in the last 2 weeks. And I've also, again, like I said, I've got the same questions in the PowerPoint presentation with the explanation about the answers as well, which I've sent to Shivani and she'll send round after this.
So to those of you who are leaving, I'm just going to add the, oh, they've already left. Okay. Well, anyway, I'm going to add the feedback link. So if you could fill it out pretty much as soon as you can, that would be really, really helpful. I will put the link in the group, but I think if I put it here, they're more likely to reply. Let's put it in. Okay, so I've added the link. So please fill out the feedback, because it's very useful in developing the future sessions and letting us improve what we're doing. So Saba has asked, how do I join the Kahoot session? So Saba, what you need to do is you need to download the Kahoot. Yeah, thank you, Remy. You have to download the Kahoot app from the App Store. Yeah, and then make an account and type in the game pen.
No, it's 838219.
Yeah, and everyone feel free to turn your microphones on, because it's nice to hear sound effects in this. Okay, is there anyone still trying to join Kahoot, or have we got everybody who would like to play? If you're still trying, just message in the group and we'll wait for you. If not, then we'll get started.
I'll join and provide sound effects.
Okay.
Yay.
Is that everyone or a few more?
I think we're just waiting for Saba because it's just loading. There we go.
Yep. If I do really badly, I'm going to be quite embarrassed.
It's okay. I'm going to point out I did this exam myself not that long ago, and I've forgotten half the answers too, so don't worry.
And we did a practice session and I didn't score very highly either. But don't worry about it.
Okay, so I'm going to get started, if that's everyone. Okay, so it's the first question. You'll have about 90 seconds per question, or if they'll end if everyone's answered. So, I'm going to read that question while everyone's looking. Concerning the distribution of blood flow in the lung described by West, which one of these is false?
Coalitions, huh?
Hi, we can't see the question.
Can you not?
Oh,
wait.
No. No. So this is Kahoot. Right. Okay. No. There's a question. Right. No, we can see it now. Sorry. Thanks. Sorry.
About 5 seconds left. Okay, so the correct answer is in zone 2, the arteriovenous pressure determines blood flow. So we're asking which is the false one. The rest of them are all true. This is one of those questions that they get. It's very pernickety, and it does come up. I'm not going to lie. There's quite a long explanation I've written on the PowerPoint, which I won't recite to you because it's quite dull for me to listen. But effectively, as Joe was saying before about West zones, zone 1 normally doesn't exist unless there's very specific conditions that it occurs in. And then the flow, obviously, it will change down the West zones themselves. So I'll give you a rough idea of the score.
Explain that one as well. Can anyone hear me?
Yeah.
Yeah.
Yeah. Please. Yes. Please
Do you remember? If you go back, do you remember
sorry.
on my? Can anyone hear? Well, never mind. I'll come back to it.
Sorry.
No worries.
Sorry. We'll go back to that.
Yeah.
Anyway, sorry. The second question is the following increases pulmonary vascular resistance. So one of these is true. Okay. And right, so for these, so pulmonary vascular resistance will actually increase with increased PaCO2, or decrease with an increased pH and PaO2. Angiotensin is a very potent vasoconstrictor, so it can increase. Hang on, that's not in there. Sorry. Cyclin is a vasodilator, and all volatiles will increase. Will cause a decrease in pulmonary vascular resistance.
And that's because they get rid of a HPV that we talked about before.
Yeah. So everyone feel free to answer. So next question. Which one of these is true regarding functional residual capacity?
Yay!
Well done. Well done. So yes, that is true. This is one of those things that comes up a lot, or a variation of this question, and there are so many tables about factors increasing and decreasing functional residual capacity. It is just one of those things you have to learn, which I know isn't very useful information, but it does come up quite a lot. But the most important one, obviously, in this case, is it is reduced during general anaesthesia. The functional residual capacity is usually 2.5 to 3 litres, by the way. Okay, well done. Okay. So next question. This is with SBA that I adapted. So what is the most likely effect of an elevated arterial PCO2 in a 19-year-old undergoing a laparoscopic appendicectomy? We do occasionally get a very odd question like this. Okay.
What?
We didn't have time to respond.
Yeah, I can't explain that. Sorry. Sorry. I don't know what was going on
Can you
there.
redo it?
I can try. I don't know how
I mean, I
to.
don't think I was going to click arrhythmias, so.
There's no point. I mean,
Yeah.
Alicia, it was like 10 seconds.
That was weird.
Probably less.
That was odd. I can't. Sorry, I don't know if I can do that one again. But anyway, that's the answer.
I think it's arrhythmias.
Yes. I think so effectively, it's what the question is asking is what are the effects of a raised PaCO2, and out of all of those options, that's the only one that's correct, basically. And that's the sort of thing, because everything, it's the sort of question you always seem to get in the MCQ. It's everything sort of looks about right, but it's usually the one you least suspect is the actual correct answer. There's a lot of effects of a raised PaCO2, and they can be divided into different systems, which I won't go too much into because there's actually quite a lot of things it can do. But in terms of this question, so a raised PaCO2 will cause increased bicarbonate retention rather than bicarbonate loss, and it will also cause an increased pulmonary vascular resistance. Influenza respiratory, it's a lot more, again, a lot more points that you just have, again, one of those annoying things you just have to learn, which is not very helpful, I know, on top of all the other things you need to learn. That one I will correct next time, sorry. Hopefully you've got a bit more time for this one. Okay, 9 seconds. The respiratory center does not receive afferents from yes, the correct answer is dorsal medullary neuron. So the arterial baroreceptors actually have very little to do with your respiratory center. They tend to have more of an effect with your blood pressure, if I'm right in saying that. Juxtapulmonary receptors, they do have give afferents to the respiratory center, and the dorsal medullary neurons don't. It is the ventral medullary neurons that do. Again, in the exam they do tend to change one word of an answer or a question, and you just have to not read it carefully enough, and that will trick you into it. So, I mean, I can't emphasize just how important it is to read the questions and the answers very, very carefully. Well done, Freddie.
I didn't even know what the dorsal medullary neurons were, but it was a bit of luck.
Yes, it was a good guess. So, question 6. In an area of the lung where BQ ratio is greater than 1, which one of these is correct? And this is, again, partly what Joe has been talking about.
Oh, God.
Okay, that's the correct answer. So, when your BQ ratio is greater than 1, or effectively a high BQ ratio is anything above 0.8, this is areas of the lung that are involved in dead space ventilation. So the alveolar gas here will equilibrate with inspired air, so your PaO2 will increase. So therefore, no hypoxic pulmonary vasoconstriction occurs in compensation. and again, your PaCO2 will decrease. So the most obvious cause here is basically what this question is asking: what is the cause of dead space ventilation in this case? Okay, well done, guys. Question 7: with reference to intermittent positive pressure ventilation, which one of these is true? This is a bit more about what Dr. Whitman talked about last week, so I'm sorry if you weren't here. Yeah, so that's one of the effects of IPPV, because it does eventually cause overall retention of sodium and water. So in IPPV, when you're lying flat, it will reduce your functional residual capacity because your lung volume reduces, and actually causes an increased VQ mismatch. It causes, again, your high airway pressures doesn't really affect your pulmonary vascular resistance so much, because you're oxygenating those areas. So out of these 3 or 4 even, the correct answer is the third one. So ready. Right. Now, next question. Regarding closing capacity, which of the following is not true? Okay. It's one of the difficult. Does everybody know what closing capacity is? Okay, so it's basically the lung volume where airway closure occurs, and it happens when your closing capacity is above or equal to your functional residual capacity. It's equal to your functional residual capacity in neonates and infants, in 40-year-olds who are lying down, and in 65-year-olds who are standing up. I don't know where those numbers come from, but that's what the books say. There's all sorts of factors that will increase closing capacity. Again, similar to your functional residual capacity, these are just lots of facts that you have to learn and lots of lists of things. And you can measure this by using helium or nitrogen concentration analysis as marking gases. And it's called Fowler's method. So it is that part of that, similar to that graph that Joe showed you earlier. And question 9. So regarding responses modifying ventilation in healthy subjects, which is incorrect? Well done. So yeah, so 4 main factors in healthy patients will affect ventilation: your PCO2, your PO2, pH, and exercise. PCO2 is the most important factor that controls ventilation. It's a linear increase between 5 and 11 kilopascals, and above that, respiratory depression will happen. PO2, there's normally a minimal response to it unless it drops below 8 kilopascals. pH is predominantly affects your peripheral chemoreceptors, and exercise will cause an significant increase in your minute volume, and it can increase above 15 times your normal resting rate and increase your oxygen to 4 liters, uptake into 4 liters a minute. And the last question regarding dead space, physiological dead space, which of the following is true? Well done. So it's the sum. So you remember your physiological dead space, as Joe said, is just sum of your anatomical and your alveolar dead space, and you calculate it using the Bohr equation, which you need your PaCO2 and your PeCO2 to know. So yes, everyone, you're almost right, but that question was a bit again being a bit sneaky. The Bohr equation is something you'll have to learn. I can't remember if they get you to. I don't think you'll get to be asked to derive it in the Viva, but it's useful to know how to do it. And there's again lots of factors that will affect your dead space, increase and decrease your dead space. So more lists of things you need to know. Okay, and that should be all. And our winner is in 3rd place. Well done.
Okay, sorry guys.
Well done. Okay, thank